Two patients walk into a clinic. Both undergo standard refraction and present with an identical distance visual acuity of 660, equivalent to N20 near vision. Yet their realities outside the exam room diverge completely. Patient A can effortlessly navigate a flight of concrete stairs, but cannot decipher standard print. Patient B, using magnification, can comfortably read N5 newsprint. But place them at the top of those same concrete stairs, and they face severe mobility issues, unable to safely distinguish the individual steps. It is common to attribute this massive functional discrepancy to subjective psychological factors, assuming one patient lacks motivation, confidence, or is simply struggling with their age. The actual cause is a completely unmeasured psychophysical deficit. The discrepancy lies in the contrast sensitivity function. A high-contrast Snellen chart only tests visual acuity at maximum contrast and high spatial frequency, isolating a single extreme data point on this curve. To understand how a low-vision patient actually processes real-world environments, faint edges, shadows, and low-contrast obstacles, we have to map the entirety of this functional vision window. Standard refraction is inadequate for low vision. The clinical exam must be structurally adapted to measure contrast slopes, map scotomas against unsteady fixation, and quantify glare sensitivity. These physical realities are measurable. A specialized protocol converts vague symptoms into the specific data required to begin a functional rehabilitation plan. We begin quantifying this deficit by approximating the high spatial frequency slope of the patient's contrast function. This requires a side-by-side presentation. We present a standard 100% contrast logMAR chart next to a 10% contrast logMAR chart, tested at a 40-centimeter viewing distance. A normal visual system will yield a difference of 2 to 3 logMAR lines between the high and low contrast charts. A drop of 4 or more logMAR lines on the low contrast chart indicates a significant pathological contrast deficit. To measure peak contrast sensitivity, we use the Pelley-Robinson chart at a 1-meter working distance. Here, the spatial frequency is kept constant. The letters subtend 3.3 degrees at 1 meter, while the contrast decreases by 0.15 log units from one triplet to the next. Tested monocularly, the clinician simply records the last triplet where the patient correctly identifies the fading letters. Next, we measure highly functional edge detection using a 630 type grading disc. This is tested at 40 centimeters with all room lights on, as it is strictly luminance dependent. Scoring is calculated logarithmically in decibels. Normal vision for patients under 65 sits between 19 and 22 decibels. A score of 14 to 11 decibels indicates moderate loss, while anything dropping below 10 decibels represents severe contrast degradation. Subjective complaints of faded or washed-out vision are no longer anecdotal. These specific tests translate those symptoms into objective, actionable data points. From contrast, we move to spatial awareness, targeting the specific visual field loss caused by macular diseases like AMD or advanced glaucoma. Standard perimetry fails here. Patients with central scotomas physically cannot maintain the steady central fixation required by automated visual field machines. Even a standard Amsler grid becomes utterly useless if the patient's central scotoma is large enough to swallow the central fixation dot entirely. The clinical adaptation is simple but structurally necessary. The clinician draws 2 thick white lines diagonally from corner to corner across the grid. By extending the target outward, the patient uses their remaining peripheral vision to align the lines, allowing the brain to extrapolate the center. This stabilizes the eye enough to map the central defect. While Amsler lacks high sensitivity and specificity for diagnosis, it is highly effective at mapping qualitative functional issues, identifying exactly where the visual field is missing, faded, or distorted. For mapping the remaining peripheral island of vision, we rely on kinetic visual field testing. Here, we must use larger targets, specifically a Roman numeral 3, 4E size or greater. Presenting small targets to a degraded visual system will only generate false negatives. Finally, we assess luminance. A low-vision patient's visual acuity is highly volatile, heavily dependent on ambient and focal lighting conditions. This diagram shows the brightness acuity test, or BAT device. This tool, along with the Berkeley glare acuity test, is used to quantify exactly how much a patient's visual acuity degrades under intense focal glare. Testing near acuity under varying lighting conditions proves whether reading physically improves with increased illumination or if it is destroyed by the resulting glare. These modified fields and glare tests map the functional boundaries of the patient's world. This data dictates if they meet legal driving standards, qualify for a blind pension, or require immediate mobility support. With objective data collected, the focus shifts entirely to actionable intervention. The low vision exam is not designed to diagnose subtle pathological changes. It is strictly engineered to measure gross functional changes. Every specific psychophysical deficit recorded on the chart maps directly to a specialized allied health intervention. A severe contrast loss, logging under 10 decibels on the EDGE test, triggers an immediate referral to occupational therapy. This data drives specific environmental modifications, like applying high-contrast paint to stair edges, installing tactile markers, or prescribing electronic pouring devices for the home. A visual field restricted to under 10 degrees mandates an orientation and mobility instruction referral. The mobility instructor uses this data to train the patient in sighted guide techniques and the use of a symbol cane for spatial navigation. A mapped central scotoma requires targeted orthoptic intervention. The orthoptist relies on the Amsler grid and BAT data to execute eccentric viewing training and design custom focal lighting plans. When we accurately map contrast, fields, and glare, the focus shifts from the untreatable pathology of the eye to the functional capabilities of the person, providing the data necessary to support their return to daily life.